Welcome, everyone, to our continuing webinar series from Sony Healthcare. We hope everyone is staying safe and healthy. We greatly appreciate everyone taking the time to be with us today. Here in 2020, the world has changed. Healthcare has changed. The pandemic situation has driven an actual paradigm shift in workflow and delivery methodology. Something I think many of us had always thought was a marketing term, but sadly, it is our reality. Our goal today is to detail how the Sony NUCLEUS platform specifically addresses some of the new requirements and emerging workflows in hospitals. As priorities due to the pandemic, capabilities critical to enabling optimal patient care have shifted. The new normal, if you will, is here now and will probably remain in place for the foreseeable future. Today, we will address three major areas where the coronavirus pandemic has had the most impact in terms of the paradigm shift and the future of hospital patient care and preparedness. Like many companies, Sony has had to adjust quickly to protect its employees and support communities around the globe and fight against COVID-19. Sony has also reacted by evaluating its technology and product portfolios to pinpoint solutions that can address the dramatic changes and stresses on healthcare workers. While the hope is that the COVID-19 pandemic will have an end date in the not too distant future, its impact on the care delivery infrastructure of health systems is now, and it's significant, and it will be long lasting. With their missions on the line, health systems need to bring creative solutions to market, obviously, as fast as possible. Most anticipate many of these changes will become permanent as hospitals recognize the need to be prepared in future-proof facilities for future events. Proactively planning, designing, and providing the tools of preparedness becomes a focus of literally all of us on this call. And again, we thank you for your time. I'm Dave Alexander, the marketing manager overseeing the Sony integration platform, NUCLEUS. Today, we are fortunate to have on the call a few key members of the core development and engineering teams behind the platform, including Mark Barron, Senior Engineering Manager, Healthcare Solutions at NUCLEUS, Marco Menares, Senior Solutions Engineer for NUCLEUS, Shogo Obuchi, Product Development Engineer and RAQA Liaison at NUCLEUS. We will, of course, have Q&A in the later part of today's session. You'll be able to speak with them directly. The most commonly cited change is that telemedicine has finally reached the tipping point. It will become a mainstream healthcare delivery vehicle, and industry analysts predict rapid growth. CMS has expanded reimbursement for telemedicine services, and this is expected to become permanent. Chris Jennings, former healthcare advisor to the Obama administration, believes the use of telemedicine has just been accelerated by about 10 years. While there's always been a need for telemedicine to expand healthcare services to patients with limited access, such as those in rural communities, the new drivers for rapid adoption are to increase patient care and create it. Number one, the purpose is to address the supply and demand crisis by enabling more patients to be seen, thanks to the efficiency of telemedicine. And two, enhancing safety for patients and clinical caregivers, i.e. using technology to do virtual visits in lieu of face-to-face interactions, where appropriate, of course, thus reducing the risk of exposure. This means telemedicine technology will also be largely adopted for use inside hospitals and clinical facilities, such as for use in today's topic, remote patient monitoring. Not just in the patient's home, in addition to doctor to patient, it'll be used for safe communication between physicians and staff, patients and administrators. AV integrators have been waiting for this moment forever, but finally it's been forced into practice, and its unforeseen importance has become inherently obvious. The need for telemedicine will no longer be a debated topic. The pandemic has highlighted the growing physician shortage as well, which has caused the role of nurses and physician assistants to be expanded. All of these caregivers will need to utilize telemedicine during such crises. We'll explain how the Sony NUCLEUS system delivers powerful telemedicine capabilities. Have a look at that chart. In this eye-opening report from the U.S. Department of Health and Human Services titled Hospital Experiences Responding to the COVID-19 Pandemic, one of the top issues cited by those surveyed was substantial challenges maintaining or expanding their facilities' capacity to treat patients. As you can see in this graphic, the situation is devastating. This data from HHS is already 8 days old, so the surges in the last week across the US have already made this chart even more magenta. Still, as you can see, many facilities are running at greater than 70% capacity. As a result of the swelling capacity, hospitals have had to get creative in utilizing all adaptable spaces and all available caregivers to handle the unanticipated number of patients. Going forward, they will need technology that will enable the various clinical spaces to be multifunctional. They also need technology that can safely and efficiently monitor more patients with fewer personnel. The HHS report further identified increased costs, decreased revenues, and significant financial concerns as a significant challenge. Furthermore, the AHA reported a total loss of $200 billion or more for America's hospitals and health systems during the 4 months March through June of this year. This highlights the need for technology that can be deployed at a reasonable cost, which can be multifunctional and scaled up as the needs arise. $200 billion in just 4 months. Monies that will not be available to fund any construction or technology spends. With the platform approach of NUCLEUS and the unique modular capability to build system functionality per application and therefore control costs, our solution has never been more important. Before we get into the details of how Sony's NUCLEUS platform can address these challenges, we'd like to give you a brief, and I promise brief, overview Sony's healthcare business for those of you who may not be familiar. You know us for broadcast, but maybe unbeknownst to you, the industry loves us in healthcare. A quick understanding of our healthcare portfolio will provide insight as to why we decided to round off the offering with this unique product. Sony has a 40-year heritage in the industry. As an OEM and provider to many major modality makers, our printers and surgical medical grade displays have set the standard in the industry for many years and continue to lead the market globally. Our recorders have been used by radiologists and surgeons for decades to capture procedures for training, education, pending the medical record. Our camera control units and PTZ cameras have also been used widely and are used in the majority of endoscopic, microscopic, and robotic surgical systems throughout the world by the major modality makers. Our printers, when it comes to printers for the OR, Sony here too also has the #1 global market share of units for hard copy imaging, a position we hold in diagnostic imaging as well, with modalities like ultrasound, C-arms, and X-ray across modality manufacturers. But you probably know us for our surgical displays. Sony is the #1 global manufacturer and reseller, or seller, of surgical displays with a full range of 2D, 3D, HD, 4K, and 3D 4K monitors in all shapes and popular sizes. Since 4K endoscopes are rapidly becoming the industry standard, surgeons the world over have come to rely on Sony's 4K displays for the finest detail and truest colors, crucial elements of their work. In fact, our pioneering continues today as we're about to launch our latest 32-inch surgical display. It is 4K, 3200 MD. We actually have a bit of it in the market very shortly. So what is NUCLEUS? Approved in just March 2020 for sale in the US, the NUCLEUS platform is an enterprise deployable video management and collaboration platform. It has a new level of configurability compared to traditional baseband systems. NUCLEUS has been successfully deployed in other global markets for several years, with over 500 ORs utilizing our technology. Since it is a network-based system, NUCLEUS represents the modern means by which to control and run an operating room, monitor patients, record and manage video and stills, broadcast and collaborate, document and monitor all types of interventions. This is in Edinburgh, Texas, one of the states being hit hardest right now. This is typical of many small to medium-sized facilities that are simply not constructed to function at higher capacities. Simply, they do not have the space. As we discussed, there is a major ICU shortage in many places, prompting facilities to look to areas, including ORs, to be converted to handle, well, overflow, for lack of a better term. Increased capacity, the capacity of care, becomes the mission. The core design of NUCLEUS lets us configure and deploy systems utilizing professional cameras and the ability to broadcast vitals and/or respiratory info to a common place. Staff safety, well, with NUCLEUS facilities can lower their staff exposure, monitor patients at a distance or at a slight distance, and do so with fewer staff in the room, provide quality care. In the educational environment, NUCLEUS allows residents and others to monitor live patients from afar or from the classroom, all via the remote monitoring functionality. This is what only NUCLEUS brings to the table. The principle is simple. Video sources are transported via the network to the central servers. Video and imagery is then transported to its destination, a local monitor, the video archive, the classroom, the pathologists in their office, wherever it's desired. NUCLEUS is secure, and to maintain a watchful eye over related network traffic as well as system components, ORs are 24/7 managed, not just monitored. A feature unique to the platform, and you'll hear a lot more about that shortly. In the patient monitoring system scenario, configurations are typically as follows. Vitals, cameras, and video from any modality are sent via the network to NUCLEUS. Again, NUCLEUS sends it to the desired destination, potentially a large screen perhaps at a central nurse's station or at a physician's office or in a monitoring area or control room, almost as existing telemetry systems function. In the OR environment, collaborate using telestration to identify markers and areas of concern to the pathologist, easily allows surgeons and nurses to monitor from the lounge or from the central nurse's station to know when a patient is ready. Since it's a network-based product, many additional efficiencies result. NUCLEUS is remote monitored. NUCLEUS is maintained remotely. Yes, it's actually a remote patient monitoring system that is itself remote monitored. But again, more on that shortly. The system is geared to utilize existing data infrastructure, key point. So that again, no new large-scale AV cabling or fiber optic cabling project is required. This saves valuable budget, deployment time, and obviously reduces costs overall compared to traditional systems. Ophthalmic ORs. One client of ours uses our technology to monitor several ophthalmic ORs from a central control room. Physicians and residents at this teaching facility centrally monitor and study live cases. With a VPN in place, the students and professors can also view live cases remotely, completely remotely from outside the network. They can study archived videos and stills, and where appropriate, all is anonymized. Remote proctoring is a terrific way of maintaining social distancing protocol and providing easy access to valuable content and curriculum. One massive West Coast IDN right now is looking to deploy a NUCLEUS-based patient monitoring system. This system will serve over 300 beds in several on-site locations with PTZ cameras that utilize PoE. Each is covered using 2 data drops, no power, no other infrastructure. This allows them to install in an affordable, fast implementation to cover more patients with fewer physical resources. Again, the flexibility of NUCLEUS allows Sony to meet the needs of custom configurations. Both applications will be publicized by Sony as soon as the clearance from the facilities is approved. Prior to the deeper technical information portion, some last quick points that we wanted to reinforce. NUCLEUS serves over 500 ORs globally, with several installations in progress here in the US. Despite receiving 510K only in late March, of course, timing that is not the dream of a marketing person. We again will publicize these as soon as we're able. NUCLEUS requires no equipment racks. Let me say that again, no equipment racks. That means no dust being collected in the corner of your nice new neuro room or in a pediatric room. Less to clean, major advantage. Geared for existing LAN infrastructure, again, no fiber is required. Save that budget, buy another room. Remote maintenance and monitoring, keep technicians out of the OR. Remote maintenance, we monitor all the components and manage software from afar, keeping technicians and costly on-site visits to a minimum. Less stress on biomed. The back end is infinitely expandable. Once you have the core of the system, you can add rooms of any type and only incur the expense of the additional hardware or the small cost of local room licenses for software necessary for the application. This makes the enterprise concept a cost-effective means of implementing the technology. The number of inputs and outputs, sources and displays is unlimited per room, as we provide the ability to escape the limitations of traditional AV switching systems. Add sources later. Turn an OB room into a CVOR easily with no new rack. Simply add decoders, add encoders as you add sources, and new rooms can function very swiftly. Smart applications, small add-on pieces of software, include many helpful software-based functions that can be added anytime, with more being introduced over time, along with additional APIs. Yes, APIs, they are an option. However, unlike others, NUCLEUS is provided turnkey with no development needed by the end user or the systems integrator. The GUI is completely developed. Like patient monitoring systems, recording-only oriented applications such as urology, ENT, OBGYN, and many of our other customers, or any type of private practice used for surgical follow-ups, can be accommodated based on the modular platform design. If you deploy only the recording software, and in urology, for example, just one source, NUCLEUS can do that, and it's very low cost. As an active member in many industry organizations and a leader in healthcare products and R&D, Sony around the world and the NUCLEUS platform are poised to incorporate many data-related analytics and other capabilities that will potentially lead to better patient outcomes. An incredible quote. IP as a means of video transport is indeed taking over. It would take an individual more than 5 million years to watch the amount of video that'll cross global IP networks each month in the year 2021. Staggering. And coming from Cisco, well, they know a little bit about the router market. IP video and network-based systems are the future of information management and distribution in healthcare. With our proprietary techniques, we put critical surgical video, including 4K, into an all-new world of possibilities when it comes to distributing, managing, and protecting valuable content. We're going to tell you more about it. Again, we thank you for attending today. We greatly appreciate your time. And for more on the technical aspects of NUCLEUS, we now pass it over to Senior Engineer Mark Barron. Mark?
Hi, everybody. This is Mark Barron. I head up the Healthcare Solutions Group in Sony Medical. The first thing I want to say is at the end of this, we're going to have a Q&A session. So please feel free to put your questions in the questions box in your GoToWebinar. If you see on the panel there's a questions pull-down box. You can enter your questions in there. All right, so I'm going to expand on what the original topic of this was, which was originally optimizing today's ORs and making them more flexible. I've expanded it to the hospital itself. So in the light of the current situation with Corona, we can start looking at what is the problem, right? If you identify the problem, then we can start moving to a solution. So these are some images I pulled off the internet. Obviously, this first one here is pretty self-explanatory, right? So they've run out of space. They don't want to go in and out of the rooms as often. So they're snaking cables underneath the door so that they can maintain the vital signs, the IV drip and things like that from outside the room. Obviously not ideal. We're going to move from a point of where things are not ideal to when they're truly even more dangerous. So that's the first case. The second one, this is at Holy Name Hospital in New Jersey during the height of the pandemic. They quickly ran out of space, so they utilized another room, actually 2 rooms. And then the hallway between the 2, they set up all the remote monitoring. This is courtesy of Time Magazine. It's a day in the life of a paramedic, Danny Kim. The link is right there if you really want to read a good article. It's full of pictures. It's very, very interesting. But obviously, this is obviously not ideal either, because now you have people, they're not going into the rooms, but it's pretty crowded, and trying to find space in a hospital is not always something that's going to happen. When that doesn't happen, then you start moving to the overflow area, which is the hallways. There's no separation, there's no privacy, there's cross-contamination, there's all kinds of issues associated with this. And then moving further down the line, you move to the Javits Center, where you have individuals that now have to move remotely from the hospital. All the equipment has to be moved, personnel has to be moved, and you have what is essentially a triage center for COVID. And then finally, you kind of get to the worst case scenario where you have a tent city that's set up. This is in Central Park, across the street from a hospital, and you're exposed to the elements. You still have all the other associated issues where you have to bring people and materiel across the street to maintain what is essentially a COVID triage area. Although it has been good for companies such as this Anchor Solutions, Anchor Industries, they are in the rental market for renting exactly this, kind of a mesh tent, where they are set up as individual overflow areas for this pandemic. So at Sony, we wanted to talk to customers, and we talk to hospitals, clinicians, IT people, facility people, and identify what is the need. Number one that we hear is nurse stress, right? We have to reduce the amount of stress for the nurses who are not only afraid of the patients, but they're also concerned about their own health and the health of their family. Cross-contamination is a big issue. As you go in and out of rooms, hand washing, people are washing their hands 20 to 30 times. So additionally, you're really working against the clock, because it's very time consuming to gown and degown your PPE, not to mention the waste of those PPEs. One of the things I've read was that you can reduce the amount of PPE use through remote monitoring of up to 70%. So in a time of crisis like this, where there's a shortage of all this material, it's very important. We also want to reduce the need for medical personnel to unnecessarily go into a room to check on something that could be remotely seen. Is the patient truly in distress? Do I need to go into that room, or can I just handle it remotely? And then also, it's very costly to move a patient from a med-surg bed up to the ICU. If you can turn that med-surg room into what is essentially an electronic ICU or a virtual ICU, then you could possibly not need to transfer that patient to the true ICU. So the answer is NUCLEUS. NUCLEUS is our video and imaging integration platform. It's a digital platform that primarily was developed for use in the operating room, but there is a need in this time of crisis where we found other use cases. I'm going to talk primarily about workflow in this presentation. In the last webinar I talked a lot about the technology underlying NUCLEUS, This is more or less how you can use NUCLEUS in different ways than what it was intended. So NUCLEUS is video over IP. So IP, Internet Protocol, it's the ubiquitous network that it resides everywhere, including hospitals, right? Everywhere has a network jack. Every room should have a network jack. The nurses' workstations, the operating rooms, ICU, they all have network jacks. And to IP, so that every one of those jacks, in essence, now becomes a routable source or a routable destination. So it's very, very efficient from the standpoint of time and cost to adapt. These things are already in the hospital, so really all you have to do is buy the underlying infrastructure of NUCLEUS itself. You don't have to hire somebody to wire a particular location. It's designed from the ground up to be bi-directional. It's just the way the Internet Protocol is done. Low latency is baked in. No one wants to wait for a long time for information to be sent back and forth across a network, and it's sent as fast as electrons will travel. And then finally, we're not confined to a predefined matrix switch. And I'm going to talk about that in a couple of slides, exactly what that means. So why video over IP? As I said, it is ubiquitous. There's a couple of different flavors. There's copper. So in those hospitals that are existing, older hospitals will have copper. In new builds, they're typically putting in fiber. NUCLEUS can handle both of those formats. We use off-the-shelf network switches from a variety of manufacturers. We're not tied to one manufacturer, and neither should our customers. We want to be as vendor neutral as possible. We use low-cost, reliable servers. Again, the servers are the backbone of the system, and I'll talk about how they enter into the NUCLEUS world. Scalability, very important, and it's very easy. As David talked a little bit about earlier, as your needs grow or as your use cases grow, it's just a matter of adding more hardware. So the hardware itself is some servers that sit in a data center and what we call IP converters or IPCs, and I'll get into some more details about that. So first, let's look at how hospitals are typically configured today. And this is kind of specific to an operating room, but they use matrix switchers that are, as we talked about, baseband being the actual video signal themselves. So on the left-hand side here, you see alphabet soup is the way we term it, BNC, HDMI. This is something the nurses shouldn't have to worry about. These are the actual physical connections to connect a modality or a source to a destination. So what this really entails is cable clutter, cables that are running all over the place, and they're also discrete cables. You only can have an HDMI to an HDMI or a DVI to a DVI, whereas with IP, it's just a network connection. They're all network connections. We see things as just either copper or fiber. You'll see that there's a large rack that takes up space. In the case of an OR, that space is very valuable and it takes up a fair amount of space in there. So as I talked about, we take all these different signals and we kind of funnel them down to what is essentially network. In this case, a copper network. It goes into an IP converter. The IP converter then sends things over the network in the back end. So the nurse doesn't have to worry about looking for an HDMI jack or a DisplayPort jack. Everything is just a network jack. What this allows us to do is have an unlimited number of inputs and outputs. We don't limit, there really is no limit other than your bandwidth in your hospital. We don't limit things on a number of use basis. So that entails, multiple IP converters on the input side and on the output side. We try to make the interface very easy for nurses to use. We don't want them bogged down with something that really is ancillary to the patient care. So we've put a lot of time and effort into using the graphical user interface, making it very simple and easy to use. Using IP allows us to have a very ready-made video distribution network. It's very cost-effective. It's very inexpensive to put in network. The cabling is very inexpensive. And we can accommodate many resolutions. In the healthcare world, starting with 4K, there's 2 different flavors of 4K. We handle that in full HD. There's 3 different versions of HD. And then of course we have to be mindful of legacy standard definition. And there's a multitude of those formats that we have to worry about. And then we get into kind of the esoteric radiology formats. We can also handle those because you never know when you're going to move a C-arm into a room, and those type of radiology modalities have square pixels. So that's why you see 960 by 960 or 1024 by 1024. And of course, we talked about the connectors that we accommodate. Every known connector in the healthcare world today is we can accommodate. As I say, going from 4K all the way down to standard definition. We strive to be modality neutral. We want to be able to work with any video signal, regardless of the manufacturer. And right now, we can say that we work with, many medical manufacturers' signals. We can remotely control certain devices, the ones that we have protocols for. As long as we have the protocols, we can find a way to manage that user interface into our NUCLEUS system. That includes competitors' displays. Obviously, we can control our own medical monitors, but there are certain competitors' displays that have allowed us to control their interfaces remotely. And we always use standards-based. Sony does not want to get into the realm of specific Sony-only protocols. We use standard-based, one of them being RTSP, real-time streaming protocol. So the NUCLEUS digital platform, the tagline is see anything, access it anytime from anywhere. We talked about modality neutral. This allows you to switch and route video from point A to point B. Streaming, very important in telehealth. We call it collaboration or broadcasting, whatever you want to say. It's getting a streamed video with very low latency from one point to another point. You could also record and archive any of the streams at any time. So telestration, it's important for training and education use cases where someone can actually help somebody understand something by drawing on the picture and seeing it bidirectionally. Very scalable and expandable. We talked about that, and I'm going to touch upon smart applications. David alluded to it a little earlier with the API that we talked about. So in the most simplistic way, you have endpoints. Those endpoints are called IPCs or IP converters. You have a transmitter. So on the left-hand side here, we have a transmitter. It transmits it over the network to a receiver, and the receiver then decodes it, puts up on a display. In between, we have our servers, which reside in the data center themselves. So within the room itself, whether the room is an ICU, an OR, or a med-surg room, this is what you'll see. This is the transmitter. It's about the size of a cigar box, and that's the only footprint you're going to see in the room. All the main brains of it go into the data center residing somewhere else on the campus. As we move up in complexity, you start adding transmitters and receivers. So instead of having maybe an endoscope, you have an IP camera. This is actually a high-end pan-tilt zoom camera that we use in our ICUs. We have 4K, we have HD, and then everything would then be set up onto the network where you can route and switch things from any point to anywhere. So one thing I really want to highlight here is the flexibility. Again, with this, if this pandemic has shown us anything, it's the need to be flexible. We don't want to have people in the hallways. We want to be able to utilize rooms that are available and maybe underutilized or underserved. So in the case where our main thrust is in operating rooms, the pandemic has really shut down a lot of elective surgeries, and those rooms are idle. It doesn't really matter to NUCLEUS whether that room is an operating room or whether it could be a potential intensive care unit. We just now use the same technology. It's an isolated room. It has a camera in it, and we can now broadcast that information or stream it anywhere you want. So the idea being it could be going to a doctor's office where the doctor can look in on his patients. You can turn a med-surgical room into a potential pre-ICU, and of course the ICU itself, we can allow nurses not to have to go in and out of the room because they can remotely monitor the progress of the patient. And all of these things are interconnected, and you can see anything from anywhere. In this case, in the virtual ICU room, we have an IP camera. That IP camera could be as a pan-tilt zoom camera, as shown here, or it could be an inexpensive fixed camera. Even there's some security cameras that are very inexpensive to get you started in monitoring remotely. There's some flexibility and some added benefits of having a pan-tilt zoom camera. For instance, you can zoom in on the patient, you can zoom in on the IV and see how much more before the bag has to be changed. You can zoom in onto the vital signs and get a sense of what's going on in the room. So there's some flexibility with that. But again, as long as it's standards-based, in this case, RTSP, which I mentioned, we can handle that signal. So the idea being, you have a central command center where you can have either a technician or a nurse who can monitor multiple patients. In this case, and we're experimenting with some of our customers in exactly how many patients a nurse would care for. So we can show up to 16 on a typical monitor. Again, these are larger monitors, 55-inch or so monitors. You can see an overhead, high in the sky view. You can also see your telemetry. You can see your electronic health record. And then the broadcast control is where we can actually zoom in to the particular case that you're looking at. So this means you can now get potentially an 8-to-1 ratio of 1 nurse to 8 patients, and then dispatch nurses on an on-needed basis to go into the room itself. So it does help in cutting down the number of times you unnecessarily enter a patient room. So this is a command center that we have set up, and this is, so you'll see up on the top here, we have our kind of eye in the sky view. You have your electronic health record, and then you have your full screen patient view that you want to narrow in on. Down here we have our vitals, and you can have many other different scenarios. This is just one that we've actually connected in a customer site. But this now allows multiple ICUs to be interconnected through our data center and to the command center. So for instance, maybe med-surg is not on the network at this moment, but you can very quickly and flexibly connect that to the NUCLEUS network, and it can become part of the NUCLEUS monitoring system. So in this way, you can actually expand the number of ICU beds virtually to med-surg or potentially the operating room. This is a higher level of detail. This is what our eye in the sky, our live view would look like. You kind of get an overhead view of what is going on in each one of the rooms, so you can see how the patient is. In addition to that, you'll see that there are a number of different inputs that we can have. These right now only are set up for room view. We can also, any video signal, for instance, vital signs, if you roll in the C-arm, you can all remotely view those through this interface. The idea would be the nurse would assess what's going on from the large view and then drill down to that particular patient through the broadcast view. And here we see we have 2 choices. This is what is potentially OR1. This is OR2, OR3 on the left-hand side here. And then we have telemetry view. We have our room view. This is 30 frames per second, full live video, and I can even go full screen with it if necessary. So all this is important, and it's really nice to have. One of the things that really comes back as a question to us is how easy is it to maintain? We have something called System Watch, which monitors the system 24 hours, 7 days a week. If anything goes above a preset threshold, we're going to be notified of it. And we have our Network Operations Center, which it's a distributed network of people throughout the United States who monitor the system. They respond to those emails in many cases before it actually manifests itself as a problem within the room itself. We back up the configurations daily. And this way, we don't overload the IT people. We're taking a lot of the responsibility for maintaining the system on ourselves. Just touch upon scalability. Very easy to scale up. If you want to add a room, you would just add one of our NUCLEUS boxes, a transmitter or a receiver. If you want to add more functionality or many more rooms, you might have to add another server. But again, that doesn't mean going into the patient room. It just means going into the data center and adding a second or third or fourth server. And the other thing is any of these software components that we have, broadcasting and our live view, these are all software based. So we can do them remotely. We don't even have to go on site and turn those on. Once the license is paid for, we can remotely attend to that and we can turn those licenses on or off. There are a couple of options. I've kind of focused mostly on ICU idea today. But routing and switching, very important in an operating room. This allows a nurse to take any modality. So down the left-hand side here, we would see our displays. Across the top, we would see our modalities. We see a live view of each one of those modalities. So for instance, this one here looks like an endoscope. I want to have this appear on screen to the left here. I just have to match the crosshairs, select that, and that's how we do very simple routing and switching. So again, the nurses don't have to worry about learning something very complex. Their primary reason for being there is patient care, and we try to make the routing and switching as easy as possible. There's presets, so when the doctor comes in the room, it could be pre-configured for either a surgery or the way the doctor likes to have the room set up. Every one of our sources can be recorded or not recorded. So we have a no limit on the number of recordings that we can do. And all of that goes to the back-end storage area network that's maintained by the hospital. So the hospital has full control over all the patient information. It's not something that Sony holds on to. It passes through our system, but is maintained directly by the hospital. And the last one I want to touch upon was our smarter applications. This was the API that David had talked about. We have a full, robust set of APIs that are available to anyone who purchases the system. This allows them to modify or customize their system without having to come back to Sony if they have a better idea. We will help them with that as far as the programming is concerned. But it's open. It's an open platform, expandable, and it's pretty much very powerful if you wanted to customize a different workflow or a different use case from what you're normally doing. So I'm going to open it up to Q&A. I mentioned earlier that there is a questions pull down. So if you want to start asking some questions, I'm going to dole it out either on the marketing side to David, or Marco Manjarez is on the call also. He's our local NUCLEUS expert. So one of the questions, could I use any RTSP encoder? There are existing cameras, encoders, et cetera, in service. I would say yes, technically it is possible. RTSP is a very robust and established standard. The only thing we would ask is that we would have to validate it within ourselves. So if you have an existing camera, you don't have to purchase a Sony camera. If it is RTSP, then you can potentially use that into the NUCLEUS system. All we ask is that we have to validate it and verify that it works correctly. Can you use a tablet to control NUCLEUS? Actually, yes, you can. There is a, when I say tablet, I'm going to say iPad. There is an iPad app that you can download, and you can use it to view and control what's going on in the OR, in that OR only. This way, you can't cross ORs and try and control OR-A while you're in OR-B. But yes, you can control and actually live view and live stream from a tablet what's going on in the room. Very interesting use case. One of the questions, how does NUCLEUS compare to Proximity? I don't know Proximity. Marco, do you know them?
No, it doesn't ring a bell, Mark.
Yeah, I mean, I can look into that and get back to you, but it doesn't, I'm not familiar with them. Let's see. In collaboration, do you have case studies or other documentation other than Sony camera and NUCLEUS? How are you specifying the audio annotation? So in the collaboration case, we can use, as I talked about, you can use another third-party encoder, RTSP encoder. We're working with a couple of manufacturers now. IP cameras, which are already RTSP enabled. Again, same answer as before. We'd have to validate those. Specifying the audio and annotation. So the annotation part of it, which is I'm assuming we're talking about is our telestration. Marco, do you want to talk about our telestration feature?
Sure. The idea of the telestration basically will be a software that is loaded on one of the client PCs. So let's say a doctor's office or a specific surgeon that you want to share information with. That person will actually run this application that will allow him to have control over the sources, over the live sources that are coming to him, and being able to automatically comment on those specific sources. The idea behind it, facilitating the fact that if at any point in time during a surgery, I need to collaborate with somebody else that has more knowledge about a specific matter, then now that I have everything on the network, I'm able to use those resources without having to have everybody inside of the room.
Okay. If it is RTSP, how is the video security handled? Assumptions, you know the IP and have VLC, you can see the video. Marco?
Pretty good question, multiple layers. So if, talking about the worst case scenario, there's an employee that knows that and wants to see it, they'll be able to see it regardless. The idea behind the NUCLEUS network is that comes into our server. You have to be part of those specific VLANs. You have to have the connectivity. You have to have passwords. And then on top of that, being able to connect to the server, authenticate with our specific network, and then open your application and try to tap on it. On top of that, any of the applications that is, any of the live video feeds that goes outside of the operating room, anything that I'm sending to a doctor's office, a conference room, a classroom, whatever it might be, is also encrypted. So you have multiple layers that I'm protecting the video to make sure that, once again, anybody from the outside is not able to do that. If you have a network person that really wants to do that, then there's still a possibility, just like with anything else.
Okay. Or lighting is controlled through tablet. Can you sync this all so only using a single tablet, making it easier to use by nurses? The basic answer is yes. So everything that NUCLEUS is just a web browser based. It's just a URL. As long as we can browse to that lighting control, then yes, we can control it and bring it into the user interface. If you want to get even slicker than that, you can create your own API. But just as the basic NUCLEUS out of the box, the answer is as long as we can reach that through the network, then we can also control the lighting through NUCLEUS. Is NUCLEUS able to be used internationally? David, do you want to answer that one?
Certainly. It is currently with over 500 rooms around the world. So there's no issues with protocol, and thankfully IP is pretty much a universal language. So there's no real limitation there at all.
Yeah, and even further than that, it's been on the market for over 10 years in other parts of the world. We had to wait till we got an FDA to start selling it in the United States. As David said, we got that earlier this year, but it has been established in many parts of the world, starting with NUCLEUS 1. We're up to NUCLEUS 3 now, so it's a very robust Sony product. One for you, Marco. Is NUCLEUS deployed on the hospital enterprise network or a separate AV network?
It's up to you, the end user. If our preference is to have it on the enterprise network, that way the hospital will have full control and you have full visibility of what's going on. But if that network is not robust enough, then we can actually deploy a parallel network and just have strong connectivity to the to the local hospital network and being able to work out. So it's completely flexible, and we can adjust to whatever is needed.
Okay. David, does Sony Healthcare Solutions have a documented cost savings statement or chart for using NUCLEUS?
We don't have just yet, but we are putting together some form of ROI examples. Very difficult thing to actually calculate with accuracy. But as the user base here in the States grows, we will be on top of all of them to look at their metrics and build that out. So it's coming, but just not yet.
Okay. The question is, are all the resolutions 60 Hertz? The answer is no. Pretty much any format that's out there, whether it's NTSC standard or whether it's European standard, 50i, 60p, 60i, 5994. I know where this is heading because we had some limitations on some of our other products, but all the resolutions are not 60 Hertz. We're not limited to the frequency. Can we expect to have information on these spec sheets in order to sell? Yeah, so David, you want to approach that?
The spec sheets themselves, of course, are all completely available within the healthcare area on the website from Sony Pro. And certainly afterwards, if there are any individuals you can't find or would like to have, you can always reach out to me and we'll be more than happy to get them to you.
And the same goes for the cost points. If you're very interested in this, you can contact us and we'll put you in touch with your local Sony representative. We can talk more about the cost, especially regarding us versus competitors, demos, try and buys, and all those other type of things. How do you mount the encoder on the monitor or boom? We have a VESA 100 standard bracket that allows the encoder to be sandwiched between the monitor and the boom itself. It's been very robust and very well designed for airflow and also for rigidity. So that way you can mount the encoder directly behind the monitor. So it's very easy to do that as long as you're VESA 100, which Sony and most of our competitors are. This is available to sell and purchase now in the United States. As David said, yeah, since March of this year. David, you want to expand on that?
Yes, it certainly is. We have several projects in process, and like Mark said, get in touch and we can connect you with pricing for any application.
So one of the things I would add to that is since the original product that came out, we usually have updates, feature updates based on feedback from our customers. Every 6 months. So every 6 months we come out with a new feature. As long as you're part of the Sony service license agreement, we do those updates, minor updates. Anything that is, for instance, we're at NUCLEUS 3.4 right now. So anything that's 3.x is a free update. When I say free, it's free as long as you have that service license agreement, which is mandatory for us to maintain the system. What happens if a network switch goes down or if there is a network interruption? So every system, especially in a critical space, has a failsafe, and that failsafe is directly connected. So let's take the case of an operating room. You might have an endoscope where the whole visual window into the patient is through that monitor. If the network goes down or if the switch goes down, it switches over. If it's a Sony monitor or one of our competitors' monitor, the switch happens automatically in less than a second. It detects that there's a problem and will automatically go to failsafe mode, which is a direct wired connection from the endoscope to a monitor. So at least you can see, you might lose the routing and switching of the other videos, but you're always going to maintain that most important video that you determine, and that's the failsafe. Marco, is it managed by an on-site server?
Correct. The backend basically has multiple tasks. being aware of the equipment, where the video is going, sending the data to specific locations, so on and so forth. So yes, the servers will always have communication with those endpoints to make sure that they are working and they're doing what they're supposed to do when the cases are going on.
Okay. Give a few minutes. I think we've gone through all the current questions.
Mark, I wanted to add two other things. First, the proximity system from Cisco is really oriented to manage content in the corporate environment. PowerPoint presentations, other videos being played in one room, accessible from another. And then second, very important factor about the finesse and design of the decoder bracket to allow you to mount this on the back of a monitor or on a monitor arm in between the VISA mount and the monitor itself. That bracket is actually like a small cage with a hinge. Literally one technician, if ever need to, could swap out the decoder for a new one versus, you know, 3 guys to take a monitor off, take your room out of service, put a new piece in place if you ever need, etc. Very slick design, and you know, we're always worried about tasking biomed with too much, and this assures that task is minimized.
Okay. Another question: is there redundancy built into the server? Yes. So the basic structure of the system is using 3 servers, and they each contain multiple containers. So everything's virtualized. It's Linux based, and in the context of those 3 servers, there's failover between each of them. Marco, maybe you can expand a little bit more on that. Each one is rated, and then there also is failover between the 3 of them.
Correct. The idea of the system and having multiple servers is the fact that at any point in time, if one of them goes out, another one of those servers can actually take on the responsibility. So you have different responsibilities per server. One is being a core, the other one's being computational modules. If any of them at any point in time suffer from a disconnect or a major failure, then the others will automatically take cover and still be able to give you the same functionality without the actual users inside of the operating rooms or whoever's managing the system noticing anything specific.
Okay. Is the data recorded locally, then sent to the server, or is it streamed to the server during recording? So I'm assuming when you say locally on the IP converters themselves. So the IP converters stream directly from the OR to the backend server in the data center, where it enters into the Sony servers. The Sony servers immediately turn those around for storage onto the hospital designated SAN. It could be, you know, a DAS, a NAS, or it could be, you know, a true SAN. So we hold on to it only as long as we have connectivity to that backend storage server, and then it's purged from our system. We do maintain the database that allows us to pull it back at any time. So if a doctor wants to review a case, as long as it's within the time frame that the hospital wants to keep it, then he's able to pull it back to our database. But the actual recorded videos, demographics, and things like that, they're not maintained nor stored on the Sony servers. I see we only have a minute left. So David, did you want to wrap up?
No, if you were done, it was literally just our pleasure to be with you today. Thank you all for your time. You will get some follow-up communication, so you have links and individuals to contact for further information. Again, we do have pricing available. Of course, there's some minor details we need on the application in order to get that put together for you. But do feel free to get in touch.
Thank you, everybody, for attending.